welcome to our PN2 lecture for Module 5. We just started the recording, and if I'm a little frazzled, it's because my internet is out, and so I've been scrambling. So I want to start out with the PowerPoint. So let me pull up my PowerPoint and share my screen with everybody. All right, I think we got that. Maybe if I can get it to let me do the slideshow thing. All right. And so I have some announcements to share, and this is proving to be quite challenging because I can't see this and my announcements at the same time. So I think what I'm going to do is actually stop sharing so I can pull up my announcement, because normally they're on my second screen. Whole new plan here for when you're having to punt and you get spoiled with all the technology. Okay, so just as a reminder, your reference page assignment for your course project, I've given everybody feedback on it. Make sure you take a look at that and make some of the changes that are in the feedback so that you don't have similar APA deductions on your paper. I think there are 2 points attached to APA for your paper, and I don't want anyone to miss out on those points. And if you don't understand, or if you have some questions about what I'm looking for, please reach out to me. I'm happy to help with that. And then our proctored pharmacology exam. Just so we're clear, I'm going to be sending out a communication to you about how you can plan and schedule to level up for your other CMS assessments, the Content Mastery Series assessments in ATI. But this isn't what I'm going to send you isn't the exam that you're taking for this course, 4 points that are assigned in this course. Okay, that test will be proctored during week 8. I'm going to proctor it rather than having you all set up a time and schedule with the proctoring site. I did it last quarter and it went really quite easily, so I'm going to go ahead and proctor it again. So it's going to be during week 8. It'll be during our live lecture time at 9 o'clock. ATI allows 70 minutes, so they time it. I have nothing to do with that, but you have 70 minutes to complete it. It's a 70 question test. And so make sure you allow enough time. You're going to need more than the hour because you were going to use Proctorio like we did last quarter. You all should have used Proctorio, and make sure it's working. Make sure there's a quick start guide that's in the ATI resources that's uploaded for you. So don't wait until the morning of week 8 to find out that it's not working. And you'll need probably, I would allow an hour and a half that day to be able to get all of that done. And then I will record what I would have covered in the live lecture for that week, because the next week is an exam week and I want to be able to provide support for all of you getting ready for that exam. So you'll have the recorded lecture for week 8, and then you'll also have a recorded live lecture for week 8 for you. So if you have any questions about that, let me know.
So I do. Does that mean, if we've already leveled up, then we're going to be taking a different one?
Yes. So if you already leveled up, if you got a level 2 or 3 on your pharmacology, I had asked students to reach out to me. I've only had 3 who reached out to me. So if you also leveled up and didn't let me know, you need to let me know. There's no, Rasmussen doesn't want you to take the pharmacology one again. They'd like you to work on leveling up on another one. So that means that whatever practice B you're doing for this week, and then the remediation for practice B and the retake for practice B should be for whichever of those proctored tests you want to take in lieu of the pharmacology. Now, if you have not achieved a level 2 in pharmacology, you have to continue to work on that in this course. Okay. So hopefully that clarifies. And there are points attached to remediation for the proctored test. There's points that you earn based on how you score on the test. And so, and then it's up to 12 points. So if you earned a level 3, you get 12 points. If you earn a level 2, you get 10. I will be sending this out with the FAQs this week, so you don't worry about writing it down. You'll have it written down on tomorrow afternoon when I send this out. Level 1, you get an 8. If you score below a level 1, you don't get any points for the test taking, but everybody has the potential to earn 13 points for remediation. So just know that that is you don't want to miss those remediation points. They add up. So even if you do score below a level one, it's important to get those remediation points. And you have to do the remediation before you can retake it anyway. So even if you were, I've had students in the past who said, I'm not doing it. And then they want during the next quarter to take the retake again and try to level up, and they're not allowed to take it until they complete the remediation. So just be aware of that. Um,
Dawn, I have a quick question about
sure.
remediation. I actually, it's not about your course, so I apologize, but I actually just signed up to do to level up for something else, not during your time, but a different time.
Sure.
And I got accepted in. I talked to my old instructor, but do I just get on at that time? I don't need to re-put that code in, do I? Do you know? Do you know how that works? We've just never done it this
Mm,
way. So
yeah.
I get on at 9 tomorrow morning and
Have the code just in case you
just
need
in
it,
case,
but I
okay.
think that you'll log in and they'll accept you, but I don't know. I haven't,
No, I'm like nervous, but I'm like, worst
I
case, I just do
know.
it a different day. I just don't want to get like a 0 or something.
Yeah. Well, just have the code with you. And then if you need
Okay.
it, you'll have it. And if you don't
So
need
it'll
it,
just show up in my proctored section. Like it'll just show up,
yes,
proctored test is available. You go in there. Okay.
I believe so. I believe that's how it works. And,
Okay.
and so, Illinois, all of the campuses on Illinois have been working towards a standardized remediation process. I'm sure, I don't know if all of you discovered last quarter, there's quite a variance in what different campuses and different instructors expect for remediation. So there's a standardized process that's supposed to be rolled out this quarter. I'm not going to enforce it until the proctored exam, so I'll have to enforce it for the proctored. All it really is if you remember last quarter, they added this kind of a summary sheet that you had to fill out. There was some information at the top, just some data about your test that you fill in, and then they wanted these three summary points. And what we've decided for Illinois, since we are requiring all the students to do one handwritten remediation active learning template for each topic identified in their topics to review, we didn't feel it was appropriate to make you fill out all of those lines on that form for every topic also. It was doing double work with it. That wasn't really added value. So we're just asking you to fill out the top portion of the remediation cover sheet. They're calling it a cover sheet. And then, but leave all those uh, key points, you can leave those blank because you've already done them in your remediation templates. There are other campuses that all they're doing is that form, and we are not, because we have proven, and nationally it's proven, that doing the remediation templates improves scores. So we're sticking with that. So if you have questions as that's being um, rolled out, please reach out to me. I don't want you to miss out on points because you didn't understand what was expected. But don't worry about any changes. Everything that I told you for practice A remediation is the same for practice B. And then everybody takes a practice B retake, practice A and practice B. Now the practice A retake is already passed, but everybody needs to do the retakes for practice B. Um, Regardless if you got 100 or not, you still have to do the retake as the practice. And then my last announcement, and I want you to mark your calendars. I put it in the announcement in Blackboard, but I will be offering a review session for a final exam review session. I'm just going to be doing one of them, and it'll be on Friday, September 11th from 9 to 11. And so you're not required to be there. It's an optional session that I'll be offering. It's not going to be recorded, but I wanted you to be able to mark your calendars and to plan accordingly if you wanted to attend that. So September 11th, 9 to 11 for a final exam review time. All right. And let's see here. This is really tricky without my two monitors. So I'm going to try to share my screen again. And we'll get into the content that we're going to cover today. Oh, that's funny, Alina. It's your birthday. I have a couple people in my life whose birthday is September 11th. My husband's grandfather was one, And I've got a nephew. Okay, can you see my screen with, it says announcements on it? If somebody would chat in. Perfect, thank you. Okay, all right. So the next slide that we're going to talk about, and we looked at this one yesterday. Can you see all of this? Um, I have the chat box that's covering up part of it, and then my WebEx screen, but I want to make sure it's not covering things for you. You can see it all, okay? Okay, looks like we're good. Okay, so we're going to just go over real quickly. We did this. Yeah, it's a blurry picture. I could not get it to come in a little clearer. Um, so I just want to, we went over this last week, but it's so important when we're talking about heart failure and some of those conditions that I wanted to do a quick review of it again today. So just remember, as the blood enters the heart, it comes from the superior vena cava, goes into the right atria. From the right atria, it goes into the right ventricle. From the right ventricle, it travels through the pulmonary arteries to the lungs, where it is oxygenated and it's able to eliminate the CO2 from the body. From there, it travels through the pulmonary veins into the left atria, and from the left atria, it'll go into the left ventricle, and then that left ventricle will pump the blood out of the heart into the coronary arteries of the heart, as well as to into the aorta, to the brain, and to the rest of the body to provide the oxygen to the cells that is needed. And so when we have heart failure, depending on where that heart failure is occurring, the area just preceding it is where we're going to see those signs and symptoms first. So if we have left ventricular or left heart failure, it's going to back up. Blood is going to back up into the lungs. And so we're going to get pulmonary edema. People are going to have trouble breathing, extremely short of breath, as compared to if we have right ventricular heart failure or right heart failure. Then that blood is going to back up in the superior vena cava, which we most often see it in the jugular veins. The jugular vein distension is one of the very first signs. We'll also see some ascites, peripheral edema. And the right-sided heart failure, another name for it is cor pulmonale, and that's a result of a respiratory disease. So the lungs aren't working well, and so that right ventricle ends up failing because it's had to work so hard to work against the resistance in the lungs. So that starts out as a pulmonary disease and leads to a heart disease. Um, and the peripheral edema we see is typically with right-sided heart failure, but with prolonged, uncontrolled left-sided heart failure, we'll also see that peripheral edema with it. Okay, so quick review just for everybody. And then the next slide I want to talk about, this is the conduction system. So just a little introduction for you because you're going to get it next quarter, but I want you to be able to understand some of it. So a normal electrical conduction current in the heart, it's going to originate in the sinoatrial node. So this SA node is where it's going to originate. And it's going to travel through the atria. So this picture only shows it in this right atria, but it actually goes all the way over to the left atria as well. It travels through what's called the Bachmann bundles. And then it comes back together at this AV node or the atrioventricular node. From the AV node, it's going to travel through the bundle of His, and then it enters down into the ventricles. And we have these bundle branches. So there's a right bundle branch and then a left bundle branch that it splits and then it innervates those two areas of the heart. And at the end are these tiny little fibers called Purkinje fibers. And so I just wanted to take a few minutes to introduce that to you just as an introduction. And uh, we're not going to spend a whole lot of time on it. You're not tested on it. I just wanted you to have that understanding going forward as we talk about some other things. Okay, so what I do want to do, and I'm going to ask for participation from you, is we're going to talk about some post-op complications of vascular surgery. So I would ask if you would politely unmute, one at a time if you can, and be patient while others are talking. And if somebody would share with me, what are some possible post-op complications that you should be aware of for someone who's had a vascular surgery?
Decreased circulation.
Okay, sure. we're going to be keeping a close eye on those, on circulation. Good.
A DVT or an embolism?
Yeah, so clots could form. You know, our body's natural reaction when we cut open a blood vessel is to form clots. And so clots could form. And when one clot forms, our body goes into this automatic mode of forming more and more clots until it determines that the bleeding risk has subsided. And so, you know, there's huge risks for clots forming. And what can those clots lead to? What things can happen if we get clots that we don't
Pulmonary
want?
embolism.
Yeah, so we could get a PE that could start. Absolutely. So, you know, we've got embolism in general. So, pulmonary means that we've got this clot that ended up in the lungs, and that's a really bad thing. People get really short of breath. They have this feeling of doom, this anxiousness, and they just, sometimes they don't even know what's going on. You know, they're like, something's not right. Something doesn't feel right. And they initially might be um, saturating still just fine, but then over time, if that clot were to grow, uh, then they would start to have some respiratory distress, but they often have that feeling of doom with it. So a PE, so that's one place that that embolism could go. Where else could an embolism travel?
The brain?
The
The
brain and
brain. Yeah, and what happens when it ends up in the brain? What do we
a
call
stroke.
that? Yeah, stroke. So we have an occlusive, um, an ischemic type stroke that could happen from it. Okay, where else could it end up? Yeah, the heart. So that clot could form and end up in one of the arteries of the heart. And so then the heart itself doesn't get the oxygen it needs. And so we have a heart attack, a myocardia infarction. So yeah, anywhere else we might see it that you may not be thinking of?
Lung?
Yeah, so the lung would be the pulmonary embolism that we talked
Oh,
about.
okay.
Absolutely. Yeah, but I mean, that's a big one. Anywhere, you know, Ron just chatted in the kidneys. It could occlude a renal artery. It could occlude mesenteric arteries. When your mesenteric arteries get an occlusion, you end up with dead bowel. It's a bad thing. I've taken care of a couple patients who have had that happen, and it's incredibly painful, and they lose the bowel, and then they end up having to have ostomies, and it's just it's a bad thing if they can't just resect the area where the clot where the ischemia ended up happening. So really anywhere this embolism could end up in the calves. Somebody mentioned the calf, so a DVT. So absolutely. All right. So we've got clots are one of the risks. What are some of the other risks that can happen?
Hemorrhage?
Yeah, hemorrhage, bleeding. So we could have a bleed. I had a patient I took care of. I can tell you it was probably one of my worst days as a nurse. I was working in an ICU at the time. I was fairly new to that department, and I had a patient who had a bilateral femoral bypass done. This patient was in his 70s and had dementia, and somebody thought it was a really great idea to start this surgery at 1 o'clock in the afternoon. So, of course, when he came back to me at 4:30, 5 o'clock, he was sundowning and was very confused. So you add the dementia, the sundowning with anesthesia, and I had a patient who was very anxious. I had a very hard time keeping him in his bed, and he's supposed to be lying still for like 6 hours. Without moving those femoral arteries, and his blood pressure was labile, it was going up and down, and it was a nightmare. It seriously was one of the worst days of my career. And he ended up actually bleeding both sites. He ended up, because of his restlessness and us not being able to keep him calm, and we were given no sedation medications for him, he broke through and hemorrhaged. And so he had these clots, and they had to take him back to surgery and evacuate the hematomas. And it was awful. I can just tell you, it was just awful. Don't wish that
Would
day
there
on anyone.
normally be on like sedation, or you
I
called a
asked for it.
doctor?
They didn't want to
You did.
sedate him. They didn't want to sedate him. And I know it was a bad
That seems
decision.
ridiculous
Yeah.
because then he had to go back into
Needless to say,
surgery.
when the surgeon was a little upset with me and was a little vocal about it, I got a little vocal back because I'm
Yeah.
like, sorry, you took a man with sundowners to surgery at 1 o'clock in the afternoon. Where was your head? What did you think was going to happen? It was not a good day. Not a good day at all. So anyway, bleeding, huge, huge issues. So we're assessing all the time, looking for the bleeding. Infection, yeah, we're going to be looking for infection. Um, um, yeah, and people do get worried about the PRNs for falls. Yeah, it was just a bad day. And I knew when they told me I was going to be assigned him, I'm like, oh, this is bad. I just had that feeling of this is not going to end well. I just know it's not, and I was right. It was not good. Okay, so our second question: how are these complications? I can't read my questions because it's covered by stuff. Um, how can we detect these complications? What assessments are we going to do? Be able to identify these complications.
Monitoring the edema on the extremities.
Monitor edema on the extremities, but what's going to show a sign? Let's say we're concerned about an occlusion. How would we um, early detect an occlusion? Let's say somebody had a vascular surgery in the femoral arteries. How would you know that there was an occlusion? Peripheral pulses. Yes, good.
Yeah,
So,
pedal pulse.
um, so the edema, if there's an occlusion in a vein, well, you could see it in an artery too. Before the blood flow, where the blood flow is coming from, whether it's an artery or a vein that has an occlusion in it. So, but the pulses tell you whether you have um, perfusion going beyond where you had that surgery. Skin temp, yeah, you're looking at the color, you're looking for feeling, checking that cap refill, feeling for those pulses. What do you do if you can't palpate the pedal pulse? Sorry, I've got some work being done outside my house on the street, so I hope that wasn't super loud for you. There's a
Doppler.
A Doppler, yes, thank you. So yeah, if you can't feel it before you say there's no pulse, you want to get a Doppler and you want to double check that. And Dopplers are pretty cool. If you haven't had a chance to play with one, um, you know, when you're in orientation as you start your jobs, get a hold of one to sit on yourself and on other people. Just you can just use the wrist. They're pretty cool. Kids love them too. They're a lot of fun. All right. So what other things we're checking? Pain. Yeah, so if you have some new onset of pain somewhere, that could be a sign. Good. I got two people chatting in pain. That's awesome. If someone were possibly motor function, that might be end up being a later sign of it. Um, some neuro changes, especially if you have an occlusion to the brain. So definitely, or numbness and tingling in the periphery. So definitely a cough. Yeah, so if they have a new onset of a cough or dyspnea, that could tell you that something's going on in the lungs.
I'm not sure if somebody already said it, and it seems kind of obvious, but vitals, especially if you're looking for a hemorrhage.
Yeah, I don't think anybody did, and that's a really important one. That's why we're doing regular frequent vital signs. And we're given parameters to check vital signs on a regular schedule post procedure, but know that you can always do it more frequently if you have concerns. So we're looking at the blood pressure, but also look at the heart rate. Remember that as your blood pressure goes down, your heart rate is going to go up, compensating for that typically. So, you're looking at both of those elements. And then, you're looking at your O2 sat for your respiratory. if you're having a PE of some kind. Urine output, absolutely. You know, if you're hemorrhaging, your blood pressure is going to drop. We're going to have less perfusion to the kidneys, and the kidneys will put out more. Absolutely. I mean, I this said that backwards. They're going to put out less urine, and so that could be a sign for us. So very good. Let's see, was there anything else on my list here that we didn't cover? Um, yeah, and then, you know, keep close eye on that abdominal pain because that could be a problem with the mesenteric arteries. All right, and so our last question, what are some typical post-op care measures that we should have in place for your patient? Yes, so we want to have SCDs or EPCs, depending on where you work. They're called different things. So we're looking for venous thrombolism um, treatment. So vital signs frequently, absolutely. We want them to cough and deep breathe. Every surgery, we want them to cough and deep breathe. Echo, absolutely. Be still. Follow the activity instructions post-operatively. So for some, they may be on bed rest for a while. For others, they may want them to get up and move quicker. So it depends on, you know, where their surgery is. So know what that activity level is for your patient for the procedure that they had done. So I saw frequent vital signs. We mentioned in the last question, somebody mentioned neuro signs. So yeah, we're going to do frequent neuro signs for this. Um, and, you know, they may actually start anticoagulants. So remember, once we've after the surgery and we've established hemostasis, meaning that surgery's done and nobody's bleeding from anywhere, we know that the clots that our body needed to protect us are formed and are doing their job. And so they will start Lovenox or maybe even heparin after. So remember, those medications don't dissolve the clots that have formed. So they allow those clots that have been formed to do their job, to continue to do their job, but they prevent additional clots from forming. And so we will start patients sometimes that very day on anticoagulants. So just be aware of that as well. So any questions about vascular surgery? Okay. So we're going to talk a little bit about bone marrow aspiration. I have some more things that I'll pop up here in a second, but which bone do we typically use for bone marrow aspiration? Not usually the femur. They could, but we have another bone that we typically will choose. Does anybody know what that is? Okay. All right, I'm going to put the picture up here and it'll give it away. All right, so we often are using the iliac crest. So this nice big bone in the hip is often what they use. They can use the sternum, but the iliac crest has a lot of bone marrow in it and it's accessible and it's got some padding around it for most people. So they often will choose that bone. So what do we need to, so you're getting a patient ready to do a bone marrow biopsy. What are some of the first things that you need for that? The doctor says, hey, we're going to do a bone marrow biopsy on
Pain
who's our,
meds.
okay, so we're going to be looking at some pain medication, definitely. Consent. Yeah, Charlie just chatted in consent. And even before we get the consent, what do we have to have from the provider to be able to even get the consent? An order, yeah. So we have to have the order and the consent. Those are like the very first things that you need when you're doing any kind of an invasive procedure. So you're going to get other things ready, absolutely, but you have to have those two things before you can proceed with the procedure. So how do we position this patient? Our picture kind of gives it away. One of the options anyway. Okay. So side lying laterally, yeah, right, right. So you're gonna, it'll be side lying whichever of the iliac crests that they're going to be getting the bone marrow from will be up, not down. So it'll be up. So they'll either be side lying or they could be prone, so laying on their stomach. They could do it that way as well. But usually we see people on their side. So what type of anesthetic is used? Okay, I see a couple chats in there. Definitely local. Yes. Um, so we're going to do local anesthetic. Occasionally they'll do a procedural sedation, or they used to call it conscious sedation. They might do that, especially if it's a child. It can be pretty traumatic for a child. Or if you have a patient who deals with some anxiety disorder, they may do that to make them more comfortable. But primarily we're just using a local anesthetic. All right. So teaching. I'm just going to share all of this with you rather than have you all chat in. So some specific teaching that you would want to let your patient know before the procedure is that it's going to take about 20 minutes to do it. And, we're going to use a local anesthetic and it's going to numb the site. But they may still feel some pressure or even some brief pain, especially during the aspiration part. So, we want to forewarn our patients of what to expect so they're not surprised and they're not fearful. And so, let them know that there'll be a little discomfort or brief pain during the aspiration, but it will go away. And then post procedure, very important. You want to apply as soon as they pull out that trochanter that they use to get the specimen. We're going to apply pressure to that site to control the bleeding. So just like any puncture site, you'll have sterile gauze, you're going to have sterile gloves on, and you're going to hold pressure to that site. Yvonne, I'm not sure the answer to that. She wanted to know how many plugs do they take for a marrow transplant, and do they take them all the same time or multiple visits? I'm not really sure, Yvonne. I will add that to my FAQs and I'll do a little research and get back to you on that. So we're going to, we're using that sterile gauze to hold the pressure. And so once we've established that we're no longer bleeding, we're going to put a sterile dressing over it. And then you want your patient to be in bed rest for 30 to 60 minutes. So your provider will give you direction on that, but minimally 30 minutes. And then, we're going to keep an eye on that site for any signs of bleeding, but also for infection. We can add ice to the site. The ice helps with comfort. It can help minimize some bleeding and even some bruising by putting ice to it. Pain is usually controlled with mild analgesics, so Tylenol, maybe they probably won't do ibuprofen just because of the bleeding risks, but usually they don't need narcotics for this pain control. So if your patient's needing narcotics, you might want to do a little exploring to find out, first of all, perhaps they have a different threshold for pain and they need a little more pain medication than an average person to be able to control their pain. But also you want to make sure that there's not like a hematoma developing below the skin that's pinching a nerve and causing that extreme pain. So make sure you do that assessment. And then we're going to be avoiding aspirin or other medications that reduce clotting. So aspirin and NSAIDs will plus our formal anticoagulants, we're going to be avoiding those post-procedure as well. Questions about bone marrow transplant before we move on to our next thing. Okay, I'm going to stop sharing for a minute because I have a Kahoot for us to do. So if you want to start logging into your Kahoot, I'm going to start getting mine ready while we're talking. And we had so much fun with having, let's see here, I don't know if I can talk and do this at the same time, having that competition with some actual results, or you got a benefit if you did well. So I'm going to do the same thing, but I'm actually going to extend it and have the top 3 winners be able to turn in an assignment up to 3 days late. So now bear with me. I am trying to find the Kahoot here. Here we go. I got it. I would have had this all up and ready if my internet had cooperated. So top three, and I don't have a pen on me, so I'll have to put it in my phone, I guess. Um, who our winners are, but be sure if you are in the top three on the podium, be sure that you let me know that it's you, because sometimes you put some really fun nicknames. Okay, so I'm going to share my screen and I'll have your game pin ready for you here in just a second. All right. So the caveat with for the winners who are going to take advantage of your late assignments, you have to let me know. It can be the day of the due date for the assignment, but you have to let me know before the assignment's due that you're taking advantage of it. You can't just not do it and then let me know the next day. Oh, by the way, I want to use that. So I ask that you have a little foresight. All right. I'll give you all a few minutes to get logged in and ready to go. Can anybody tell me in the chat how many people we have in the group? I didn't get to see that, and it doesn't let me see it when I'm sharing my screen. Okay, we've got 18 with us. Okay, that'll work. We're going to run a little over to be able to get through everything. Hope I pass. I love that name. You're definitely, if you win, you're going to have to let me know who you are. All right. Do I have anyone else still trying to log in? Chat in if you are. If I just have 10 players, we'll run with 10 players, but I don't want to take everyone's time up if no one else is going to participate. Okay, we're going to get started. Which laboratory value is assessed for a client receiving a heparin infusion? All right, correct answer is your APTT or partial thromboplastin time. Let's see who came in. All right, we've got Claude, Renee, and Tosh. Next question. Therapeutic APTT levels for a patient on heparin will be how many times greater than normal? All right, correct answer is 1.5 to 2.5. All right, Renee took the lead. Claude and Tosh still in the top three. Therapy for B12 deficiency includes which of the following? Cobalamin therapy. All right. Ooh, zebra kisses, 69. Was fast there. Awesome. Renee and CM. We've got a whole change in order here. Ooh, this will be fun. Won't be a blowout like last time. The advair discus works in what ways? All right, it's a bronchodilator and decreases inflammation. Good. Ooh, look at this. All right, next question. Which medication reduces inflammation? All right, prednisone is the correct answer. Renee is still in the lead. Zebra kisses and Echo right behind. Which medication is a fast-acting bronchodilator? The correct answer is albuterol. And we've still got Renee in the lead. Zebra kisses and Echo. And usually it gives me order. With my smaller screen, I can't see everything, so. All right. Which medication is a long-acting bronchodilator? That would be Ceravent. All right, Renee in the lead, Zebra kisses, and CM. Ooh, good job, CM. Which medication is a cholinergic antagonist? Tiotropium or Spiriva. All right. Renee's still in the lead. No change in order this time in the top three anyway. Which medication combination would be prescribed for tuberculosis? That would be rifampin, isoniazid, and pyrazinamide or pyrazinamide. Renee, Zebra kisses, and Echo. Which laboratory values should be closely monitored when treating tuberculosis? Liver function tests are correct. All right, we're still pretty close. Renee, zebra kisses, and echo. Which symptom of a client taking lisinopril requires most immediate action? The correct answer is facial swelling. That is a sign of angioedema. All right, Renee's still in the lead. Zebra kisses and echo. Beta blockers have which effects on vital signs? They decrease blood pressure and heart rate. All right. Furosemide has which effect on electrolytes? All right, it decreases potassium levels. Good. All right, Renee's still in the lead, but Zebra Kiss is right behind. Factor VIII recombinant would be given to a client with which of the following? Fifty-fifty chance here. All right, correct answer is hemophilia A. So factor VIII and A sound similar. So if that helps you remember that, factor VIII and hemophilia A. All right, we've got Renee, Zebra Kisses, and Echo. And Tosh is not too far behind either. So, which condition can increase risk for digoxin toxicity? The correct answer is hypokalemia, low potassium. Ooh, we've got a change in the lead. Zebra Kisses took the lead. We've got a race here at the end. Protamine sulfate is the antidote for which medication? Correct answer is heparin. Very good. All right. Zebra Kisses, Renee, and Echo. And let's see here. Tosh isn't too far behind either. Vitamin K or FFP are the antidotes for which medication? All right, warfarin is the correct answer. Good job, everyone. All right. Tosh moved ahead of Echo. Look at that. She must have been super fast that time. We've got 3 questions left. Which medication is a thrombolytic? correct answer is alteplase. Do we get a change in the score? Nope, looks like we stayed about where we are. CM moved up a little bit. Good job, CM. Which medication reduces allergic responses? Last question is singular, or I'm sorry, this one is singular, and now we are going to be at our last question, but let's see where we stand on the podium. Ooh, CM moved up. Zebra Kisses and Renee still in the lead. And last question. Which medication is a platelet inhibitor? All right, the correct answer is clopidogrel or Plavix. Are we ready to see the final results here? See who's going to be getting a free late submission for up to 3 days late? Here we go. See the podium. Echoes, number 3. Renee. And our winner is Zebra Kisses. All right, so Zebra Kisses in particular, you're going to have to let me know who you are. All right, I'm going to stop sharing here for just a second and see if I can get this Kahoot taken care of. There we go. All right, so we are a little over our time right now. Now, there was another activity that I do when we have time to do. And let me pull my slide up just to show you what it is. And I'm going to explain it and I'm going to encourage you to do it. Usually the students, what I will do is have students work on it on their own. There we go. Went too far. And then I usually just have 1 or 2 students share what they did. So I'm going to explain it to you. I encourage you to take the time to do it. It's actually a good practice to do mentally for yourself every time you have a patient. And I call this what could go wrong. And so I gave you some client information for your live lecture activity. I posted it out there for you to be able to print off. And what I ask students to do is I want you to create a scenario. This is what you know about your patient, but I want you to create a scenario where your patient condition declines to a point that warrants perhaps a rapid response. So what would change for that patient that would prompt you to call a rapid response? So how do their vital signs change? What would their labs look like? What would their physical assessment look like? What could change? And then I usually have students, couple students who are courageous to share what they came up with, and we talk about it a little bit. But I'm not going to take the time to do it today. If you choose to take advantage of the activity and you want my feedback, you can email it to me and I will respond to you and let you know my thoughts on it. But otherwise, with our late start here, I don't want to take up any more of your time for your day. So I'm going to stop sharing and then open it up for any questions that you might have for me.
Question about lab. Are we just taking the quizzes as well?
Oh no, we have lab. There's lab activities and there's quizzes. We still have 2.5 hours of lab today.
Okay, I just wasn't sure if it was just the quizzes.
Nope, it's not just the quizzes. So normal full lab time, it's actually a very full day. First part of it, you'll work independently, then you'll have your quiz, and then we actually have a debriefing time. We'll talk about a few things and an activity that we'll do together the last half hour.
So do we go to the WebEx room to start with? And
yes.
Then, okay.
Yep.
That's
You'll be in the WebEx room and we'll work our way through it, and hopefully in the half hour I have before it starts for the first group, I figure out my internet issues. I'm not sure. Not sure what it is because I reset my router and my neighbors have internet, so I'm not sure what's going on. So hopefully we'll figure it out. Otherwise, I will be sitting here hijacking my neighbor's Wi-Fi for today till we can get it sorted out. All right, any other questions? All right, I'm going to stop recording.